All right, guys, welcome back. Russell Linville here again. We are going to be talking in this lecture about differential diagnoses of the hip, looking at contractile tissue disorders rather than previously we talked about inert, and we're also going to be talking in the future about neuro disorders, peripheral nerve disorders, and surgical considerations. So this is part 2 of 3 lectures. So we're going to try to understand the following differential diagnoses, and these are all going to be musculotendinous related. So hamstring strains, adductor strains, hernia, athletic pubalgia, hip flexor strains, quadricep strains, gluteal tendinopathies, IT band syndrome. And what I do when I think about these areas of the hip, the anterior, medial, lateral, and posterior, that's where I try to fit these things into my bucket. And so these differential diagnoses rather fit into the following buckets. And so this chart looks a little confusing with all the lines going everywhere, but you can pause it here and kind of see where I would suspect if someone had came in and said, hey, I have anterior hip pain, then I'm going to be thinking more of a hip flexor or quadricep strain before I move into, think they have gluteal tendinopathy, right? So usually the muscle disorders are closely related to the anatomy and where the anatomy actually is in relation to the quadrant of the hip, if you will. So as we move on here, we're going to start talking about the anterior hip first after we go into a little bit of a couple slides here on anatomy. And so just such a complex intimate relationship of anatomy here between all the nerves, the joints, the bones, the ligaments. And so, the hips are so powerful. They propel us forward during walking, gait, running, all those types of activities. You have to have a lot of different muscles that can contract really forcefully and in great concert with each other to provide some really great human movement. And then when these muscles are either untrained or maybe you haven't gain much strength in those muscles, you can lead to poor movement patterns, poor motor control. And so it really is a symphony of muscle activating at the appropriate time to give good quality human movement. And you can see just all the complexity of the muscle tissues here. You can pause this and look at this, of course. We'll keep going through. The picture on the left is going to be more of the anteromedial thigh, all the way from the inguinal ligament up here down the chain, and seeing some of the adductors and the anterior thigh musculature here as well as the neurovasculature. And the picture on the right is also going to be the deeper layers here. So all the superficial structures removed, the deeper layers of the anteromedial thigh. This is going to be looking more at the gluteus region. So you have the picture on the very left that's going to be showing you the glute max, well, the TFL, and how those blend together into the IT band and where they attach near the Gerdy's tubercle on the anterolateral portion of the knee. You have, of course, you can see just like, okay, the IT band's here. You can see a little bit of the quad muscle extending posteriorly, and then also the hamstring muscle, the biceps femoris attaching, and they all kind of generally attach in the same area. With a lateral sort of attachment point, but because of their attachment points and the line of pull when the hip's extended or flexed, that will determine what happens down at the knee. So just review some of that. The biceps femoris is a knee lateral rotator. You have the IT band or the TFL, which could be a hip flexor / internal rotator. The glute max is a hip abductor. And then what's it do when the knee's flexed or extended? These are the things that, the surface level, okay, you know what the muscles' actions are, but in relation to other movements, what do they do? And so one of the muscles we think about, that is the piriformis. And so the piriformis muscle is going to be one that really we try to, let's see if I get a picture of the piriformis here somewhere. Piriformis is here, attaches to the sacrum and then onto the femur. So when the hip's flexed, it does either external, I think it's internally rotator of the hip when the hip is flexed. When the hip is extended, it's an external rotator. So, that muscle in particular the action changes based on where the hip position is. And so if we go back a slide here, more of the glute anatomy, go forward a slide, you can see more of the adductors now, the deeper layers, as well as the medial thigh here. And so the medial thigh is very complex. We don't think about it as much maybe as the quadriceps or the hamstrings, but a lot of these muscles actually come from the hamstring bunch and and coming down and attach on the pes anzarine down here, which again, the pes anzarine is a collection of several tendons rather that attach in this similar area on the anteromedial portion of the tibia, proximal tibia, and there's a bursa there as well. There's also just general, I guess we say it's called general friction syndrome that it can occur at the pes anzarine bursa. And so similar to IT band syndrome, which we'll get into later. We're not getting into pes anzarine bursitis here. That'd be more of a knee lecture type of thing. And but I do want to show you how all of these long strap muscles kind of come in and attach in that area and why that's an important area to understand. So let's look first at anterior hip contractile tissue pathology. So we're going to look at both hip flexor strains and quad strains here. Hip flexor strains. So what is a hip flexor to start with? Well, you got 4 of them for sure. Maybe some people might argue 5. So you have your psoas major, your iliacus. Sometimes we combine those 2 together. Then you have the proximal rectus femoris tendon. So as part of your quad muscle system, the rectus femoris, the proximal portion, the tendinous portion, is a hip flexor, and because it crosses both the knee and the hip joint. Then you have the proximal sartorius, which you might not think of sartorius being a hip flexor, but it is just based on its anatomical location. It's also a weak hip external rotator and a tibial internal rotator. And I want you to, a sartor is, I think, Latin for shoesmith, if I'm not mistaken. And the other interesting part is it attaches into the pes anzarine area, which is Latin, I believe, for goose foot, because the 3 or 4 tendons that attach into that area kind of look like a foot of a goose. But anyways, that's how you can kind of remember those. That's how I used to remember them in PT school. And then finally, the tensor fascia lata can be considered a hip flexor as well. General considerations here. Hip flexor strains are more common in males than females, often seen in athletes who participate in sports that require sudden changes in direction. The risk of developing a hip flexor strain may also increase with age, as the muscles and tendons of the hip may become less flexible, may be more prone to injury. Some of the demographics here include, we talk about males greater than females, but really people of any age, gender, activity level, but they are more commonly seen in athletes or individuals who participate in activities that involve repetitive hip flexor movements such as running, jumping, kicking, or dancing. And I would say that kicking, like in soccer, may be the most likely that I've seen. I've also seen punters and kickers in football for this issue as well. So signs and symptoms are pain and discomfort of the front of the hip or groin area. This is the most common symptom of a hip flexor strain. Usually there is a known MOI. Swelling or bruising may occur if there is like a tendon rupture or a muscle belly injury, but bruising may be, again, more common with the tendon rupture. Difficulty walking or lifting a leg, just because during, as you're thinking about initial swing, or should I say pre-swing to mid-swing, you're trying to flex the hip through the bringing the foot off the ground, and so you're probably getting some discomfort with the active motion there. Might feel stiff, like you really need to stretch it out. Reduced range of motion, again, that might be indicative of that stiffness feelings you might have, and especially into hip extension. So differential diagnosis, because of the location of pain right in the anterior hip, could be hip FAI or labral tears, adductor strains if you feel it more in the groin area, hip OA, or quadriceps strain, and we'll talk about that one later. So what are some tests and measures you can do? These are some really, really great orthopedic tests. 2 tests here. The top picture is Thomas' test, and the bottom picture is Eli's test. And we'll go over both of these in the lab week as well, some of the nuances of the testing position. Strength testing of the hip flexor. So again, you're going to look at those 5 ones we talked about in the first slide: psoas, iliacus, proximal rectus femoris, sartorius, and TFL. In severe cases, you may have gross loss of strength, and then an MRI may be indicated because of the potential for a tendon injury, especially the proximal rectus femoris tendon. So interventions here, first you're going to do activity modification, possibly rest, avoid activities during the acute inflammatory stage that aggravate the injury. Rest is probably just going to be for a day or 2. Maybe in that time you're thinking about modalities, tissue work, needling, all those things, and then you're starting to get them moving again. Things, probably should never rest fully with a hip flexor strain unless there's a tendon rupture, and things like light cardio, bike, pool, things like that if you want to get the person moving, maybe there's some modified versions you can do with less discomfort. Modalities: ice, heat, compression, over-the-counter pain meds, especially if there's an acute inflammatory response, maybe NSAIDs, naproxen, those things can be used. Physical therapy, of course, this is our bread and butter, but includes stretching, strengthening, stability exercises, motor control exercises. So you're really going to treat the stage of healing that they're in. If they have an acute injury, of course, you're going to think about tissue healing timelines and adjust your interventions accordingly to the stress and strain you think they are able to tolerate. In severe cases, especially, again, the rectus femoris tendon, the proximal rectus femoris tendon can rupture, and I have seen a few patients over my career, not many, that have had this repaired back down to the AIIS. And so there you have it. Quads strain. So the picture on the right is of Saquon Barkley, otherwise known as Saquad Barkley, because he's got just massive quadriceps. So I thought the picture of him was fitting. But the quadriceps, of course, you guys notice, is a muscle group composed of 4 muscles: the rectus femoris, vastus medialis, vastus lateralis, and vastus intermedius. And of the quadricep muscles, the rectus femoris is the most frequently strained. The rectus femoris originates at the ilium, thus crossing both the hip and knee joint along its course. So it's a 2-joint muscle, which may make it more susceptible to things like passive and active insufficiency, leading to a higher rate of injury than the other ones that are just maybe 1-joint muscles. This anatomy allows for hip flexion and knee extension. Acute strain injuries of the quads commonly occur in athletic competitions such as soccer, rugby, football, basketball, all these sorts of high-powered cutting and agility sports. So here we have general considerations, and this is taken from a study called Diagnosis and Management of Quadricep Strains and Contusions by Carey. And so you can see the clinical grading for a quadricep strain: grade 1, 2, and 3, mild, moderate, severe. You can look through the chart here on the characteristics of those grades with strength and on the physical exam in terms of if there's a palpable defect on some of the musculature. The picture on the very right is of Caitlin Clark. Of course, my wife's from Iowa. That's why I live up in the great north of Minnesota, and so we're big Iowa women's basketball fans. We're sorry to see them lose recently in the national championship, but as I was making this lecture, I threw a picture of her in because she was just dominating. So hopefully next year turns out better for them. The demographics: across 25 sports, higher quadricep strain rates were found in women versus men, in competitions versus practices, and in preseasons versus the regular season. And that's an interesting stat. The preseason versus regular season could have to do with conditioning, tissue preparation, those sorts of things. Acute on chronic workload ratio. Maybe you're having soft tissue injuries because of those sorts of things. Most quad strains were minor in severity, although further surveillance is needed to better examine the risk factors associated with these injuries. And that's from the study by Eckert et al., Epidemiology of Quad Strains in National Collegiate Athletic Association Athletes. You can look that one up. Hip, I've noticed as this says hip flexor strains, it should say quad strain, so excuse that typo there. But signs and symptoms here of a quadricep strain: pain or discomfort of the front of the thigh. Most common symptom here, maybe felt sharp, stabbing, dull. Swelling or bruising. A severe case, if there's a mid-belly tear of the quadriceps, you might know something like this. This picture is actually likely of a contusion. Someone took maybe a lacrosse ball or something off the thigh, but you might see something similar in a quadriceps tendon tear, as well as a palpable visual defect in the quad muscle. Weakness or muscle fatigue, and then reduced range of motion. Again, that stiffness, inflammatory response might make it feel stiffer. So quad strain, again, possible contributing causes. Recent and previous quad injury is probably the most likely. Same thing goes for a hamstring injury. Again, recent hamstring injuries might also make you more prevalent to the quad injury because you're just having poor muscle balance in the limb. Dominant kicking leg, that just goes, if you just think about how you would rear back to kick a ball, your leg would go behind you into hip extension. Knee flexion, that's going to add onto that passive insufficiency, and then you're trying to forcefully kick out of that. Okay, so then individual player characteristics including age, weight, flexibility. This had no association with future quad muscle strains based on the Peach et al. Study that's listed at the bottom of the screen. Differential diagnosis, we're thinking contusions, femoral neck stress fractures because of the location. Jumper's knee, maybe if it's a little lower if it's like a distal quad strain. Skiffy, right? Remember, if you talk about the Skiffy lecture, the lecture with Skiffy in it, rather, that we have adolescent athlete with an insidious onset of maybe knee pain or hip pain. This is going to be differential for a quad strain if there's no real reason they should be having this. So distal quadriceps tendon rupture and then cancer. Unexplained thigh pain in pediatric patients should be looked at more closely, unless there's an actual mechanism. Like, let's say, again, baseball players about to hit a ball, the pitcher throws it, it hits them in the thigh, right? They get hit by a pitch. Okay, that's a mechanism of injury for a quadriceps injury. We would call that a contusion, right? But if someone came to you or came to direct access and they brought their 12-year-old to you and they were having thigh pain and there was no identifiable mechanism, what I would do is try to get them seen by physician as well as starting PT, because I'd want to make sure that there's an image done to rule out anything like osteosarcoma or something like that. That could be like a bone cancer, which is seen in the pediatric population. So what are some tests and measures you can do? You can do things like the Thomas and the Eli's test, again, as you do with a hip flexor. But direct palpation, so if it's tender in the muscle belly, that's going to be a high indicator that they have a muscle belly injury, especially compared to the contralateral side where it would be non-painful. Passive knee flexion may elicit pain because put on stretch. Resisted knee extension might cause pain because you're activating the muscle. And severe, again, or if loss of function, you should get an MRI. Interventions are just like other muscle strains: activity modification, modalities, over-the-counter pain meds, PT, maybe surgery if it's a really bad one. If you tear your quad, mid-belly, the chance of you getting surgery on that is 0, essentially. You have 4 quad muscles that help. You have extra hip flexor muscles that help. So if let's say you have a mid-belly rectus femoris tear, well, you're probably going to have a palpable defect there. You're not going to have surgery in the mid-belly of the muscle. It's just not repairable tissue. But you have other muscles that will help support, and your playing days might be over from an explosive standpoint, but at least you might be able to get function back. Very good. So that was the anterior hip, and next we'll talk about the lateral hip. And in the lateral hip, we're going to talk about gluteal tendinopathy and IT band syndrome. So first, gluteal tendinopathy. So also known as gluteal tendinitis or tendinosis. And again, you need to know the differential between those two. So tendinopathy is an overarching word that can encompass both of those. But this was what I consider the rotator cuff of the hip. The muscles that may create gluteal tendinopathy are going to be your deep gluteal rotators, the deep 6, we would call them. And these all share a common attachment point roughly on the femur. And so just like the rotator cuff stabilizes the humeral head and the glenoid, the deep rotators have a role in doing the same sort of thing for the hip complex. And so is a common cause of lateral hip pain, particularly in middle or older individuals. And so here's some of the anatomy that I was describing. So of course you have your gluteus medius, you have your gluteus minimus, you have your piriformis, you have your superior and inferior gemellus, and your obturator internus, and obturator externus as well. But these muscles make up the vast majority of these deep rotators that help you stabilize the hip joint. And they share, as you can see, similar anatomical relationship here. If we look here, you see how all these muscles, the gemelli and the internus, obturator internus, all share a common tendon. We call this the conjoint tendon. So that's just a stronger reinforced tendon that has 3 muscles blending into it. And so all of these together operate to help rotate and stabilize the hip. And so you can get tendinitis in these areas. This is looking at a different view of the hip. You're looking at basically a top-down approach. So of course the acetabulum would be kind of where my mouse is here, and you have the anterior portion of the thigh and the posterior portion. You can see the gluteal muscles coming in here. Again, this is the conjoint tendon. Is going to be the gemelli and the obturator internus. You see piriformis, and you can see obturator externus coming in. Also, the insertion point of some of the other muscle groups are listed here. So this just, I want you to get used to the anatomy here. And so this is just, this picture in the middle, piriformis is here, they reflect that back. Then you see the conjoint tendon, they reflect that back. Then you see obturator externus. And so you can just see how all of these kind of reinforce each other. So gluteal tendinopathy, this red area is going to be where they mainly feel it. Okay, so if you had a body chart, it would look something like this. Lateral hip rather. The exact cause is not well understood. It's believed to be caused by a combination of factors, maybe repetitive stress, muscle imbalance, poor biomechanics. Activities that involve repeated hip abductions, such as running, cycling, can increase the risk of this. But a lot of times it's just older age individuals, particularly women, who might have not the best tissue resiliency, and so they just end up getting like a tear to the tendon. And so it could be something mundane in their life that they're doing, repetitive degenerative overuse. And so a lot of times it's misdiagnosed, but older ladies, especially men too, but I think more prevalent in women, that walk with a Trendelenburg gait, they might have a tendon rupture to some of these muscles, which is causing that hip weakness. So the signs and symptoms: pain and tenderness in the lateral hip region, particularly over the greater trochanter. Worse with activity, particularly activities that involve hip abduction or external rotation. Stiffness, limited range of motion, weak gluteal muscles, pain that radiates down the thigh as well. So again, possible contributing causes, I think age is probably the most likely. Other things like obesity, trauma to the area, of course trauma all the time. And then differential diagnosis, we're thinking trochanteric bursitis is probably the number one differential diagnosis there. Hip labral tears, sometimes labral tears can present laterally, but most of the time those are going to be anterior and groin. Piriformis syndrome, certainly, but that's going to be more neurological. We'll talk about that in the next lecture. Same thing with lumbar spine pathologies. And then, yeah, hip osteoarthritis can give someone the feeling of lateral or deep glute discomfort. But this is you're going to have an exam that's going to more better able to differentially diagnose. And remember what your hip OA clinical practice guidelines and clinical prediction rules show you. So that's a way that you can differentially diagnose some of these. And again, you can have these in combination, but in isolation, you can test these things differently because one's inert and one's contractile, and you know how to differentiate between the two. Test and measures. The biggest one here is probably palpation and Trendelenburg test. Again, anything that's going to affect the contractile ability of the the combination of those gluteal tendons is going to elicit either pain or weakness. And so you're going to try to put your patient through those in the exam. So interventions here, well, you want to meet your patient where they are at physically. And so the picture on the right is just a lot of glute exercises. There's not, these aren't like what I would do for every single patient, but you meet the patient where they're at. Are they a younger athlete with just a tendinitis-y type of thing? Are they middle-aged? What's their background in fitness? What's their tissue quality? Are they a smoker? Are they older aged? Or what's their consideration of their prior level of function? What's their base of fitness? Are they fall risk? Remember, we want to make sure that these people get strong, these really older individuals, because we don't want them to get a femur fracture when they fall, because we talked about the mortality rates with something like that. So this is an area where if someone's dealing with some hip pain, you want to make sure you address it and you try your best to get them better, and hopefully they do. So things like glute max, glute medius strengthening, balance proprioception work, gait training, functional exercises, core, hip strengthening, and non-painful ranges. And so that would be my treatment approach. And then now let's talk about IT band syndrome. We had a group present on this the other day. They did a great job, but let's go a little more in depth here. So what is IT band syndrome? Well, it's a very common condition that causes pain in the outer side of the knee. And the reason we're talking about in the hip lecture is because of the proximal contributions down to the knee. And so all these things start at the hip and they insert down into the knee, and the symptoms show up at the knee. But a lot of the treatments that we do are at the hip, okay? So it's caused by irritation of the IT band, a thick band of tissue that runs from the hip to the knee to stabilize the knee during movement. This picture on the right shows you the glute max. You have your glute medius here, as well as your TFL. All of them have this kind of fascial connection that goes down. is kind of blended in with the lateral quad here, the vastus lateralis, and then it inserts into Gerdy's tubercle on the anterolateral tibia. And so all of these muscles have contributions into pulling or tensioning on the IT band, and so then can cause essentially a friction syndrome here with the bursa that lies beneath. The pain is usually felt in the shaded area here. The prevalence of IT band syndrome varies, but is more common in athletes and runners, cyclists, any sport that engages in repetitive knee flexion and extension. More common in females than males, particularly in their 20s or 30s. Possibly due to difference in hip and knee biomechanics compared to males, such as wider hips, maybe an increased knee valgus angle. Those biomechanical things in males versus females may contribute more to a higher incidence in females with IT band syndrome. The one thing about this picture that I like is they've kind of cross-sectioned or cut away the IT band here, so you can see the bursa that sits right underneath there. And we used to think that this was like the IT band itself getting injured. Back when I was in PT school, that was how it was taught to us and what we would read in textbooks. Now I think that theory's kind of evolving, and we're assuming it's probably more of this bursa that's near there, is the bursa becoming inflamed or fibrotic even, and causing kind of this abhorrent rubbing in that area. And we also think that people maybe with larger lateral femoral condyles, right, might increase pressure into this area, and that's just from an anatomy standpoint. And so anatomical variations might predispose someone to this as well. But yeah, that's the bursa we're talking about. Signs and symptoms: pain or aching outer side of the knee, most notably in the painful arc of flexion extension around 30 degrees. Pain may be sharp or dull, may worsen with activity, particularly running or downhill walking. So that increased load under knee flexion conditions might cause increased pain. Tenderness and swelling, stiffness, tightness, might have a clicking or a popping, like a snapping sensation there. All right, possible contributing causes, again, anatomical factors such as your bony anatomy, training errors, biomechanical factors, inflammation and irritation, so just for the repeated nature of someone's sport who gets this. The differential diagnosis, I think the number one thing is going to be a lateral meniscus tear, and we're talking about like a degenerative meniscus tear versus a traumatic one, because IT band syndrome some that comes on with repetitive overuse. So again, knee OA, bursitis, knee ligament injuries like an LCL, you just make sure there's no trauma. Stress fracture, certainly, but those are usually seen more proximal. And then hip pathology. So maybe something like, we talked about skiffies before, how they can refer to the knee. Maybe there's a contributing or maybe referred pain down to the knee. You just want to check the hip. What are some tests and measures? Well, Ober's test is kind of in the literature as the number one, as well as Noble's compression test. Both of those are pictured. Top is Ober's, bottom picture is Noble's compression test. The Thomas test, again, we can use this to assess for tightness in the hip flexor, which, we think about the TFL, maybe that's going to show us some, hip flexor tightness, and maybe we can address that as the TFL blends into the IT band. Palpation can help identify this, and that's basically what Noble's compression test is. So interventions, again, a lot of these soft tissue, muscular tendinous injuries, all kind of the same treatment approach. You're going to have activity modification, especially in these runners and these cyclists that don't want to stop. They really have to, for a period of time, either decrease their load or switch their training modality to accommodate their painful symptoms. Modalities: over-the-counter pain meds, physical therapy, biomechanic intervention, especially looking at maybe gait, running gaits, and hip and foot and shoe and knee, and all those sorts of factors that runners will have to consider. Now let's look at posterior hip contractile tissue pathologies, and here we're really going to talk about hamstring strains. So what is a hamstring strain? Well, it's an injury that occurs when one or more of the hamstring muscles, which are located at the back of the thigh, are stretched too far or they tear. The hamstring muscles consist of three muscles: the biceps femoris, the semitendinosus, and the semimembranosus. And these muscles work to help flex the knee and extend the hip. So we want you to review the tendon strain grading scale, grades 1, 2, and 3. Review those, okay? So general considerations, there's 3 types of hamstring strains, and we're going to focus on all of them really, but the most common that you'll see is probably going to be the more proximal and mid-substance one here. So proximal hamstring strains, delineated in this image as number 1, is going to occur at the origin of the hamstring muscle near the ischial tuberosity, often caused by sudden forceful movements such as sprinting or kicking. Can be particularly challenging to treat. The hamstrings muscles are under high tension at this location and may require a longer period of rest and rehab. The mid-substance hamstring strain is probably the most frustrating one. That's going to be delineated by number 2. This occurs in the middle of the hamstring muscle. Usually the short head, the biceps femoris, is the most involved here because that's a primary decelerator of the knee as you're sprinting. And then these strains may be caused by sudden change in direction or overstretching of the muscles. And of course, then you can have also a distal hamstring strain occurs at the insertion of the hamstring muscles where they attach to the knee. Sometimes these can be a rupture, but really these are kind of rare. Demographics, younger individuals who participate in high-speed running or cutting sports, maybe more common in males and females, particularly among athletes, more common in younger individuals like those in their 20s and 30s. Not many high schoolers get hamstring strains. It's going to be more your college athletes. One of the most common signs and symptoms of hamstring strain is pain in the back of the thigh or the buttocks, even up to the ischial tuberosity where it originates from. You're going to have swelling and bruising in really bad cases of the picture on the bottom right. The muscles may feel weak or difficult to use. It could feel stiff. You could have trouble extending your knee passively. Baseball is probably one of the highest rates of hamstring strain sports. It's actually the number 1 injury in professional baseball is hamstring strains. And if you think of the nature of the sport where you kind of get warmed up, then you sit around for a while, and then you're expected to sprint or take off or run, that's when kind of these injuries occur. So range of motion, again, may be limited, especially into hip flexion or like a straight leg raise position. And so obviously we're thinking of passive and active insufficiency. How can you tension or lengthen the muscle? In those positions is going to be more aggravating. Contributing causes, again, sports, sprinting at full high speed is probably the number 1 way these get injured. Individuals who have had a previous hamstring injury are the most likely to have another hamstring injury, and there's tons of literature on trying to figure out why these are so recurrent, and they're really, really frustrating for patients, and they're frustrating to treat. There's so many different types of hamstring strains. I mean, we generally said the proximal, mid-substance, and distal, but there's even a deeper layer of what tissue's involved, where is it involved? Is it more at the musculotendinous junction? Is it the tendon itself? Is it in the muscle belly? Is it in, there's so many more ways to look at this, and it's pretty complex. Differential diagnosis, you're thinking of muscle contusion. Because of the pain in the posterior thigh, you may think sciatica or piriformis syndrome, something like that. Lumbar disc herniation with radicular symptoms, adductor strains because some of the medial hamstring muscles are in close relationship with the adductors, and then the sacroiliac joint dysfunction, which may refer pain down the leg as well. So tests and measures here, palpation, that's what you're going to do. Number 1 with almost all these muscle injuries, you're going to palpate. If it's painful to touch in the area where they describe, a pain or pop or whatever, then you can be sure that that's likely going to be the area where the tissue is affected. Muscles don't lie very much where, you push on it and it hurts elsewhere. It's usually going to hurt where the actual tissue damage has occurred. Range of motion testing. So again, think how would you lengthen the hamstrings and how would you shorten the hamstrings? That's going to tell you how to test. But really things like the slump test, straight leg raise test, passive knee extension. And then a lot of times these individuals, we do want to get imaging if they have big bad bruising because we want to see if there's a tendon rupture. For intervention, I want to defer to the clinical practice guideline of hamstring strain injuries in athletes, and you can find this in the supplemental material on Canvas. So finally, let's look at medial hip contractile pathologies, and we're going to look at adductor strains or adductor strains. And so I like to differentiate between the two because I think with my sometimes southern accent, then I will kind of mumble my words and it'll sound like the same word. So adductor or abductor, I'll try to delineate between the two that way. Athletica pubalis is the other diagnosis here. So adductor strain, so what is, where does the adductor insert into? And it's going to be down near the pubic bone in the pelvis as well. So, here we have it. So these are some areas where you can palpate to see if someone's having adductor or pubic related groin pain. And, you can follow the pictures there to see what they're doing based on the color coding. Here's where groin pain may show up. And so adductor strains and also athletica pubalgia, these are all kind of closely related in this area of groin pain or adductor pain. So here's the area where shaded in where you might have a patient tell you they hurt. So let's talk about adductor strains first. Well, adductors, strain could be a tear or rupture of the adductor muscles, and there's several muscles that help adduct the thigh, and that starts with the pectineus, the obturator externus, the adductor brevis, longus, and magnus, and the gracilis as well. If there is a tear or pop or a rupture, the athletes will often feel a pop, may have abnormal stress of the pubic bone or pubic pressure. Pubic symphysis may feel weird. Pubalgia osteitis pubis is a collective term referring to disorders that cause chronic pubic pain. And so maybe there's a tendon injury there, and then there's inflammation, and then the pubic bone and the pubis is, so to speak, out of alignment. I hate that term, but maybe there's some abnormal stresses going through there, which gives you pubic pain. Maybe you've had a previous adductor strain that's caused that. Symptoms from increased mechanical stress in the pubic region due to abnormalities or stress from, again, osseous, ligamentous, or muscular activities is kind of what I just described. So general consideration, it's caused by repeated trauma from sports or rupture. Diagnosis often made through exclusion of other pathologies. Full history, medical screening, and differential examination of the pelvic lower abdominal is vital to ensure appropriate diagnosis. Treatment is based on severity, duration, symptoms, etc. So demographics, common in exertional sports, cutting sports, especially ones that involve lateral cutting or a lot of hip abduction and external rotation. It's often a strain during activities, again, that cause sudden changes in direction or twisting motions. Hockey is one of the main things as this happens, and you can see the extreme adduction that occurs with hockey, especially hockey goalies, and then someone like a soccer player trying to kick a ball. Those extreme positions of the thigh might put them more susceptible. So signs and symptoms: pain from kicking, running, sprinting, squats. So functional activities hurt in the groin area, tenderness over the muscle belly. Also, we talk about like the hamstring strains. You can have a proximal, mid-substance, or distal. You can have the same thing here with the adductors, especially like the gracilis or the adductor magnus or longus. You can have more mid-belly muscle strains as well. So let's just call that what it is. Possible pain and limited range of motion with passive hip flexion or abduction. Possible weakness of lower abdominals or any components of the musculature because of maybe that pubic area pain. So this picture on the right is one of my patients, Team USA hockey goalie. She is a silver medalist, so she's really fun. She's signed a waiver to let me use her in lectures and things like that, and she's on my Instagram. But her name's Grace, and she's a very skilled athlete for Team USA. But I threw a picture of her on here just because this happens in hockey, and I want to give her some credit for going through a kind of a strenuous rehab with me. So functional implications, again, pain with sporting activities is pretty much the number one thing. So possible contributing causes: muscle imbalance, trauma, like slipping with the leg going to abduction, increased tone of the iliopsoas or rectus or hip adductors. So, we think of like hip flexors and hip flexors also have, if you think of like the TFL, also might have an internal rotation bias to it. When we think about hamstring muscles, trying to collect my thoughts here because I want to make this point clear. The adductors are sometimes lumped into the category of hip extenders, depending on where the femur is rotated. So you can think if the hip is rotated in internal rotation, that might set the adductors up to act more like hamstring muscles in terms of hip extension. So if you go into passive hip extension with internal rotation and the hip flexors are tight, are we adding more stress to the adductors as well? I guess that's the question. And same thing, opposite thing, if you go into hip flexion with external rotation, are you stretching the hip adductors more so? And of course, abduction, horizontal abduction of the hip, those things are going to put strain on the adductors probably more. So differential diagnoses: pubalgia, athletica pubalgia, pelvic sprain, again, osteitis pubis, lower abdominal, rectus abdominis strain. We want to think about with these diagnoses around this area, this groin area, is do you have a hernia, inguinal hernia or a sports hernia? Sports hernia is also known as athletic pubalgia. We'll talk about that next. And so these are all things that you want to take into account. How would you test and measure this? Well, diagnosis based on patient history, signs and symptoms, and they elicit pain with palpation of the pubic tubercles, the inferior pubic rami, rectus abdominis, adductor muscles or tendons. Passive hip abduction hurts, resisted hip adduction hurts. Imaging, this MRI at the bottom right shows a adductor tendon injury. Or the interventions based on severity of symptoms, but again, muscle strain, general, activity modification, over-the-counter pain meds, and then progressive increase in stress to these muscles over time. And so there's some really cool exercises that you can come up with to help these people get back. So what is athletica pubalgia? It's also known as a sports hernia. It occurs with a weakening of the muscles or tendons of the lower abdominal wall, but there's no palpable hernia. So a real true inguinal hernia is going to probably occur with something like a high intensity effort, maximal effort, squat, back squat or deadlift or something like that. So there's an actual event, and these with high loads and intra-abdominal pressure. And so what happens is the wall of your abdomen can rupture, and then you can have things herniate out of it. And so you can actually feel like a bulge, right? Or you can actually reduce a bulge in some cases. That's not what this is. This is something different. We'll get into what this is in more detail on the following slides. You can see that this picture here is showing you that this individual is going to kick a soccer ball, and how the pubic area, in addition to the rectus abdominis, the obliques, and the adductors, all kind of share a stress in this area when the leg gets taken back into this position. Here's some other positions of athletes looking at this area. So athletica pubalgia could explain something like this: a tearing of the fascia in this area. Could also explain, a distal rectus femoris tear. Could also explain a proximal adductor tear at the conjoint tendon, or sometimes we might even call these adductor micro tears. And so the way that I think about an adductor strain versus athletica pubalgia is athletica pubalgia is a collection of symptoms around this area, and an adductor strain is probably something that you can more pinpoint identify. This is a cool picture of the pelvis looking at the inguinal ligament and how you have some vessels and then some other ligamentous attachments that attach in here. And so those areas also can get injured. Here's another look kind of at that area in a different way, and how their rectus abdominis and the adductor longus are blended pretty closely into that. You have the pubic symphysis here. And then if you think about this cross section of where these things attach into the pubic bone here, you're going to, here's another cross-sectional area here to get you better anatomy. But seems to be a common shared, anatomy between the two. So insidious onset of deep chronic groin pain radiates along the inguinal ligament, perineum, rectus abdominis, adductors. Symptoms are worsened with endurance running, kicking, coughing, sneezing, and Valsalva maneuver. Physical findings include tenderness along the external ring and the posterior wall of the inguinal canal. There may be testicular pain present in males, making testicular pathology important differential diagnosis. So that's something that you need to consider if you're working with male athletes. It's okay to ask about pain in their testicles. Actually had a patient 3 days ago. As a baseball player, he came in. He's having pain in this area, as I'm writing these lectures, and so it was top of mind. But of course, I was able to ask him about testicular pain or deep groin pain, and luckily none of that was going on with him. But it's okay, and you should ask to try to differentially diagnose, even though it might make you feel a little uncomfortable. Okay, demographics. More common in males and females, usually between the ages of 20 to 40. Often seen athletes who have a history of previous injuries to the groin, maybe people with poor or weak muscles of the core. Unknown the exact incidence, but may account for up to 6% of sports-related injuries. It's estimated that athletic pubalgia may account for 18% of all chronic groin pain injuries. So again, signs and symptoms: intense pain at the time of the injury, pain during sports movements, pain that radiates down to the adductor muscle region. Pretty difficult for them to pinpoint sometimes. Any exertion that increases intra-abdominal pressure, such as sitting up, coughing, sneezing, right? If it's the lower abdomen that's affected, then some of these things that increase intra-abdominal pressure would hurt. Pain radiates down toward the scrotum and or inner thigh. Pain may go away after you've rested, but comes back as soon as you do sports again. Can affect the individual's ability to perform daily activities in sports as the main functional limitations. Contributing causes here: repetitive stress, weakness in the core muscles, muscle imbalances, maybe previous injury, poor biomechanics. Maybe there's a genetic predisposition. Are there anatomical variants that might set someone up to be susceptible to this? Or all things that may be contributing. Differential diagnosis, I think certainly inguinal hernia is probably number one. Osteitis pubis, adductor strain, certainly up there. Hip labral tear, FAI. What are some tests and measures you can do? Well, no special tests really exist with high degree of specificity to diagnose this condition, so it's based on kind of a cluster of subjective as well as physical findings. But pain with resisted hip flexion, trunk flexion, hip adduction, all those things might clue you in. And then difficulty or pain with straight leg raise, possible pain with passive hip abduction, putting something on a stretch there. Intervention, you're going to try to meet them where they're at, of course. All those things that may be possible contributing causes, you can try to address those in PT. Stretching where they're tight, strengthening where they might be weak. You're trying to limit eliciting those symptoms, but pelvic floor exercise might be really good for these people too, getting deep pelvic floor muscles stronger to form maybe a stable, strong base to build off of more distally. So that's my approach. You can read through this. This is just a link that you might have to type this out, but this is just titled hernia surgery, but this goes into athletic pubalgia a little more in depth and was a reference for me in this this PowerPoint. All right, thank you guys. This is lecture 2 done. We got one more lecture. That's going to be your peripheral nerve and surgical lecture. Thanks.